Hello everyone and welcome to this lecture today, which is speaking about supraventricular tachycardia, as is the start of specific dedicated lectures for each type of tachyarrhythmia. And today we are starting with SVT. So our ILO today is to learn how to diagnose SVT in ECG, to learn their subtypes and their mechanism, and to identify the ECG features associated with SVT. And again, we are not talking here about acute or long-term treatment of SVT. We are just concerned with the ECG diagnosis. So of course we remember the scheme which divided tachycardias into narrow-complex tachycardia and wide-complex tachycardia, and each one of them was divided into regular and irregular. And so we mentioned last time that we have four subtypes of tachyarrhythmia: regular narrow-complex, irregular narrow-complex, regular wide-complex, and irregular wide-complex tachycardia. Today we are focusing on SVT. So, of course, in order to understand, SVT is a form of regular narrow-complex tachycardia, and it has three major subtypes. The first type is the AV nodal reentrant tachycardia, or abbreviated as AVNRT, which has two subtypes, typical and atypical. We have as well AV reentrant tachycardia, which is correlated with the accessory pathway and having two subtypes, the orthodromic type and the antidromic type. And we have atrial tachycardia, which has three mechanisms: automatic, reentrant, and triggered atrial tachycardia, and it can present in one of two forms in the ECG, either unifocal or multifocal. So let's start with AVNRT. AVNRT, of course, is one of the most common types of SVT, and of course by incidence is the most common one, and is more common in females, and is characterized by presence of dual AV nodal physiology in these patients, which is present since birth, but usually it manifests in the middle age or sometimes even as old age, although it is not impossible to find AVNRT in young or adolescents, but is more common to be in the middle age. So in this patient, instead of just one pathway passing through the AV node from the atrium to the ventricle, we have two extranodal connection called the slow pathway and fast pathway. So of course we remember this diagram. This diagram was representing the reentrant circuits in the patients with tachyarrhythmia, and here it is one of the most famous examples for reentrant circuits. We have here two pathways: slow pathway, which is characterized by shorter refractory period and slower conduction, and remember the letter S for slow, short, slow; and fast pathway, which have longer refractory period but it has faster conduction from its name. So when there is a premature piece that comes in a critical time, it becomes plugged antigradally in the fast pathway, as it has a longer refractory period, so it makes sense. So, because it is plugged in the fast pathway, it passes antigradally through the slow pathway, and then when it reaches the fast pathway, it has recovered from refractoriness, so it passes retrogradely through the fast pathway, leading to formation of a reentrant circuit and the start of tachycardia. So, AV nodal reentrant tachycardia is the most famous example of reentrant tachycardia due to presence of two pathways, which is slow pathway and fast pathway. Of course, we have two types of AVNRT. The typical type, which is the slow-fast pathway, in which the antegrade limb of the circuit is the slow pathway and the retrograde limb is the fast pathway. So as we can see here, that it passes antegrade in the slow pathway and then retrograde in the fast pathway. This leads that the retrograde P wave appear very short after the complex, because of course the retrograde conduction passes through the fast pathway. So of course P wave will be very close to the end of the complex. So it can show short RP interval, as the P waves are very close to the preceding complex, and they are retrograde P wave because atrium here is stimulated in a retrograde direction instead of antigrade direction as in sinus rhythm. Or sometimes it may be buried within the complex because there was simultaneous atrial and ventricular depolarization, so you may not see any P waves, absent P wave, as we can see here. This is of course the most common type of AVNRT. We have another type of AVNRT, which is the atypical AVNRT, occurs in about 10% of patients, in which it is reversed. It may be like fast-slow or slow-slow. Fast-slow, it means that the antegrade conduction passes through the fast pathway and then retrograde to slow pathway, or we have two slow pathway with difference in conduction velocity and refractory period, so antegrade in slow pathway and retrograde in another slow pathway. So here, of course, because the retrograde conduction to the atrium occurs through a slow pathway, there was long RP interval, as there was delayed activation of the atrium in a retrograde fashion, so there was long RP interval, as we can see here. So we call this atypical AVNRT because it is less common and it is reversed to the typical form, which is slow fast AVNRT. Let's move to the other type of SVT, which is AVRT, AV reentrant tachycardia. This patient is characterized by presence of an accessory pathway. Accessory pathway, of course, is one of the famous pathways that is, of course, present since birth. It is something considered to be congenital, but it is not a must that he will present during childhood. He may present during childhood, during adolescence, or even in middle age. But usually it presents at a younger age than AVNRT. The accessory pathway is another pathway that bypasses the AV ring at connecting the atrium and the ventricle apart from the AV node. It's characterized that it's exciting the ventricle more rapidly than the AV node, but in a slower conduction because it conducts through the ventricular muscle fibers, not through the His-Purkinje system. So we have two forms of AVRT. It may be an antegrade conduction through the AV node and His-Purkinje system, and then retrograde through the accessory pathway. So I expect, because the antegrade was through the His-Purkinje system, it leads to rapid ventricular depolarization with narrow-complex tachycardia. So orthodromic AVRT is a form of SVT. But what if the reverse occurs, which is less common, but of course we may say it, that the antegrade conduction was through the accessory pathway and then retrograde to the AV node? Because antegrade accessory pathway conduction, it will conduct through the ventricular muscle fiber, it would lead to slower ventricular depolarization and ventricular conduction, so it will lead to wide complex tachycardia, which of course would not be a type of SVT here. It would be classified in the differential diagnosis of wide complex tachycardia as antidromic AVRT. So we have the orthodromic from its name, also it meaning like something straight or something like in a reverse pathway. So it goes antegradely through the normal pathway AV node but retrograde to the accessory pathway. Antidromic from its name, it is against all the rules, so it passes antegradely through the accessory pathway and then retrogradely through the AV nodes. Of course, orthodromic AVRT is showing the antegrade conduction through the AV node and then the retrograde through the accessory pathway, so it would show short RP interval as typical AVNRT, although it would be slightly longer than the RP interval in the AVNRT. It would be like more than 70 milliseconds, for example, but it is still short RP interval. So orthodromic AVRT shows short RP interval as typical AVNRT but slightly longer. Now let's move to the other type, or the third type of SVT, which is atrial tachycardia. Of course, we know that atrial tachycardia may have one of the three mechanisms explaining it: automatic, reentrant, or triggered. But the most common type is the automatic type. There are multiple foci in the atrium which can act as ectopic foci in order to initiate atrial tachycardia. Of course, the most common origin for atrial tachycardia is the crista terminalis, as it is like the ridge or the muscular ridge between the SVC opening and the IVC opening on the inner surface of right atrium, and this is the most common origin for automatic atrial tachycardia. We have as well the pulmonary veins, which of course is a very common origin for atrial tachycardia in the left atrium. But of course, we have other organs that can give rise to automatic atrial tachycardia, like the right septum, like the coronary sinus ostium, like the tricuspid annulus or mitral annulus. So we have various origins for atrial tachycardia. If we need to classify atrial tachycardia according to mechanism, as we mentioned, we can classify it into automatic atrial tachycardia, or we call it sometimes focal atrial tachycardia, which is the most common type of atrial tachycardia. It is just like in an ectopic focus that has abnormal automaticity in the atrium, either right or left atrium, and it takes the upper hand from the SA node and overrides it. So this patient will have rhythm coming from the ectopic focus inside the atrium, not from the SA node, as the SA node here would watch and see this chaos starting from the atrium. We have as well the reentrant atrial tachycardia, which is more common in patients with structural heart disease, like for example patient with rheumatic heart disease or patient after mitral valve replacement. There is like fibrous tissue inside the atrium, and so a reentrant circuit starts around this scar tissue, making reentrant atrial tachycardia, which is less common, and it is very difficult to occur in structural normal heart. And we have triggered atrial tachycardia, which is caused by triggered activity, like for example indigestion toxicity. Of course, atrial tachycardia, because here the focus, as in the most common type, automatic atrial tachycardia, start in the atrium and then passes antegradely to the AV node. Usually we would say long RP interval, because here the P wave is nearer to the following complex than the preceding complex, because it is not retrograde P wave, it is antegrade P wave, but from an abnormal origin other than the SA node. So here atrial tachycardia would show long RP, other on the contrary to the AVRT or AVNRT. If we need to classify atrial tachycardia according to AV relationship in the ECG, it could be, of course, atrial tachycardia with one-to-one AV conduction, that we can see one-to-one PR relationship. Each P wave, which is an abnormal P wave, is followed by one complex, so it is one-to-one conduction. Or it may show 2-to-1 AV conduction, like each two P waves are followed by one complex, so one of them is conducted but the preceding one was not conducted, and we can have atrial tachycardia with variable rate of AV conduction. So the first two types would show regular rhythm, while the last type, which is variable rate of conduction, would show irregular rhythm. So this is another way to classify atrial tachycardia apart from the mechanism. Here, for example, we can see that there is P waves that show slightly abnormal morphology as it is pointed from its tip. So it seems like, despite the axis may seem like sinus rhythm, as it is positive in inferior leads, negative in AVR, biphasic in V1, but the morphology is slightly abnormal for sinus rhythm. So this is focal atrial tachycardia that may arise from the upper crista terminalis, and this explains why the axis seems like sinus rhythm, but the morphology is abnormal. And it shows one-to-one AV conduction, as proved by the one-to-one AV relationship in the ECG. Here we can see that we have also abnormal P wave morphology, as we can see here in V1 that it is completely positive. We know, of course, that the P wave usually in V1 is biphasic, but here it is pointed and it is completely positive in V1, suggesting an abnormal morphology that may be, for example, arising from the pulmonary vein and going forward to the V1. But we can see that we have two P wave. One of them is superimposed on the T wave and blocked in the AV node, so it is not followed by a complex, while the second one is followed by a complex. So we have atrial tachycardia with 2-to-1 AV block or 2-to-1 conduction. So this is another pattern of atrial tachycardia. Here we can see that we have abnormal morphology of P waves as well, and there is slightly apparent conduction as there is right bundle branch block. But what is most characteristic is that there is irregular rhythm despite the presence of persistent P wave, so it is not atrial fibrillation. And the pattern of AV conduction is variable. Sometimes it is 2-to-1, sometimes 3-to-1, sometimes 1-to-1. So this is atrial tachycardia with variable rate of AV conduction, which is a less common presentation, but it can occur, and it doesn't exclude the diagnosis of atrial tachycardia. Of course, in atrial tachycardia, there are two phenomena that we need to be oriented with. There is something called the warm-up phenomena, which is the gradual acceleration of the heart rate at the start of atrial tachycardia. So, for example, when a patient is in sinus rhythm and then he starts to develop automatic atrial tachycardia, the heart rate is not fixed from the start to the end, but it starts, for example, like 140 beats per minute, and then it gradually increases to reach a peak heart rate. This is what we call warm-up, as the atrial rhythm is warming up. And then we have something called cool-down phenomena, which is a gradual deceleration of the heart rate at the end of atrial tachycardia. And this explains that the heart rate in automatic atrial tachycardia is not completely regular. It may show slight irregularity, especially at the beginning and at the end. And this is one thing is characteristic for automatic tachycardias, either automatic atrial tachycardia or automatic ventricular tachycardia. Whereas in reentrant tachycardias, like in AVNRT or AVRT, the heart rate is usually fixed. It would not show these phenomena. So, for example, here we can see that there is an acceleration of the heart rate at the start of the rhythm, and then in the middle it starts to decelerate, showing cool-down phenomena. So this is what we call atrial tachycardia, showing warm-up phenomenon and cool-down phenomenon. Of course, we have another form which is common to see from the atrial tachycardia. As we know that we divided atrial tachycardia according to the mechanism into automatic, reentrant, and triggered. We divided them according to the AV relationship into 1-to-1, 2-to-1, or variable rate of AV conduction. And according to the origin, we can divide them into unifocal or multifocal. In multifocal, there are multiple foci inside the atria, which give origin to abnormal rhythm. So, for example, one focus here fires, giving rise to a P wave followed by a complex. Then another focus fires, giving rise to another different P wave morphology. Then another one giving rise to a different P wave morphology. Another one, another one, another one, another one. And so we have here completely different P wave morphologies in one strip, and it is still 1-to-1 AV conduction. And here's the SA nodes, which is well functioning, but because of this chaos, it is just watching this rebellion inside the atrium. So here in this pattern, we have multiple foci firing in the atrium, but they fire in a synchronized way, that each one fire one time followed by the other one. So here in this ECG, we could see in the strip of V1 that we have at least 3 different P wave morphology and at least 3 different PR intervals. So we can call this multifocal atrial tachycardia, which is sometimes abbreviated as MAT. So this patients have multiple foci, abnormal foci, inside the atrium leading to this rhythm. Here as well, we can see from these arrows that we have at least 3 different P wave morphology, at least 3 different PR interval, irregular irregularity, and one-to-one if relationship shows this is multifocal atrial tachycardia. Of course, we know that this type of tachyarrhythmia is very common in patients with COPD, and it is a benign type of arrhythmia that may need just symptomatic control, like rate control, in order to control the symptoms, but it is not significant. Some literature correlates the multifocal atrial tachycardia to increased risk of developing atrial fibrillation, so we may need to follow up this patient regularly. So now we can summarize what are the ECG features of SVT. It is regular narcomplex tachycardia. It shows P waves that may be absent sometimes, so because they are hidden inside the complexes due to simultaneous atrial and ventricular depolarization, or they may be shortly seen after the complex because they are retrograde P wave like in AVNRT and AVRT. They may be seen shortly before the complex like retrograde P wave coming late as in atypical AVNRT, or sometimes they are antegrade P wave like in atrial tachycardia, or sometimes it may show 2-to-1 AV relationship or even variable rate of AV conduction. So in SVT you would see regular narcomplex tachycardia, P waves may be absent, seen after the complex, before the complex, 2-to-1 variable rate of conduction. All of these patterns for P wave are accepted. So here, for example, I can see regular narcomplex tachycardia, and here the P waves may be slightly appearing after the complex, but it needs much more concentration. Here as well, we can see regular narcomplex tachycardia, and the P waves come here superimposed on the T wave. So remember, of course, that 12-lead ECG should be recorded in 2 situations, as we mentioned in the first lecture of tachyarrhythmia. During SVT, in order to document the SVT for the patient medical treatment, and also if we decided for ablation procedure, so we need to have a documentation of the ECG, which helps us to know where is the expected origin for this tachycardia in order to decide where to start ablation from. And after termination of SVT, as it may show evidence of manifest pre-excitation, and so it gives a clue that this SVT was orthodromic AVRT, as the resting ECG show delta wave, wide complex, and short PR interval suggestive of Wolff-Parkinson-White syndrome appearing in the ECG as manifest pre-excitation. So here, for example, an example that during SVT, just regular non-complex tachycardia, after termination it shows manifest pre-excitation, and it may show normal resting ECG, which could occur with AVNRT, with atrial tachycardia, or sometimes with AVRT in case of concealed accessory pathway. So let's have a clinical situation in reality. Now I see a regular non-complex tachycardia. What should I diagnose it? Of course, I would diagnose it as SVT. How can I subclassify this SVT in the ER? Of course, we can divide this into 2-to-1 AV relationship or 1-to-1 AV relationship. 2-to-1 AV relationship has 2 possibilities: atrial tachycardia with 2-to-1 conduction, which we discussed before, and atrial flutter with 2-to-1 conduction, which would be discussed in a separate lecture. But if it is 1-to-1 relationship, we can subdivide it again into short RP tachycardia versus long RP tachycardia. As we understand that SVT with 1-to-1 relationship, it can be short RP. Short RP meaning that the RP interval from the start of the complex to the start of the following P wave is shorter than the PR interval, which is from the P wave to the start of the complex following it, as we can see in this example. Short RP tachycardia, of course, occurs more commonly with typical AVNRT and orthodromic AVRT, because in this patient, of course, the retrograde P wave appears shortly after the complex due to retrograde conduction to the atrium. But in long RP tachycardia, we can see here that the RP interval is longer than the PR interval, as we see in this ECG example. And this happens with atypical AVNRT, which is retrograde P wave, but passing retrogradely through the slow pathway, so it is delayed. Atrial tachycardia with 1-to-1 conduction, because it is antegrade P wave, so it appears nearer to the following complex rather than the preceding complex. And of course, sinus tachycardia is classified as long RP tachycardia. So let's see this example here. We have here regular non-complex tachycardia suggestive of SVT. But what we can see here is that we can see like slightly apparency or like a notching at the end of the complex appearing in lead 2 3 AVF, appearing in AVR and in V1. This is what we call pseudo R wave and pseudo S wave, because they are seen on the complex appearing as an R dash wave or S wave. So here, these pseudo R and pseudo S are actually retrograde P waves. So here the RP interval is shorter than the PR interval, as we know from the first example. So this is short RP tachycardia, because the retrograde P wave is nearer to the preceding complex than to the following complex. But pseudo R pseudo S is retrograde P wave. So why pseudo and why R dash and S wave? Of course, they are pseudo because they are not actually part of the complex. They are actually retrograde P wave. But because they are very near to the complex, they seem to be part of the complex. So the retrograde P wave, which was positive in V1, is called pseudo R dash because it appears like an R dash wave. And the retrograde P wave, which was negative in the inferior leads, it appeared as pseudo S wave because it appears as an S wave part of the complex. This pattern, of course, is very characteristic of the typical AVRT, because in typical AVRT, the retrograde conduction occurs over very fast pathway, so they are very near to the complex, that sometimes they may be hidden inside the complex or appear fused with the end of the complex. So the presence of pseudo R and pseudo S wave is very suggestive for typical AVRT. How could we know that they are pseudo R, pseudo S, and to make sure that I am true and they are not actual parts of the QRS complex? Just to repeat the ECG after termination, you would see that they disappear after SVT termination. So of course they were not parts of the complex, they were retrograde P wave, and when you terminated the SVT, they disappeared. Let's see this example here. We can see regular non-complex tachycardia, and we can see that there are retrograde P waves here. They are negative in the inferior leads, they are positive in AVR V1. So of course they are retrograde P wave because the axis here is reversed to the axis of the sinus rhythm. And in the ECG strip, I can say that there is a negative P wave following each complex. So here I'm speaking about short RP tachycardia because simply here the RP interval is shorter than the PR interval, so it is short RP tachycardia. Here in this example, we can see one of the characteristic features that sometimes is common to be seen in ECG. We could see that there is an alternate variation in the complex amplitude in this strip. In lead 2 here, during SVT, there is like longer, then shorter, taller, then shorter, taller, shorter, taller, shorter complex on alternate beats. And after termination of this SVT, this pattern disappeared. So what is this called? This is what we call pseudoelectrical alternans. It is like a peak-to-peak variation in the QRS amplitude in absence of pericardial effusion in patients with SVT. And when you terminate the SVT, it disappears. And why it is called pseudo? Because electrical alternans is a classic ECG sign that is seen in patients with massive pericardial effusion as the heart swings in a pendular motion inside the pericardial fluid. So we call this pseudoelectrical alternans because this patient has no pericardial effusion. It is just an ECG sign accompanying SVT. And of course, one of the very famous facts about this is that it is suggestive of orthodromic AVRT, but also remember that pseudoelectrical alternans is a matter of heart rate itself rather than the mechanism of SVT. And so it may appear more common with orthodromic AVRT because in general, orthodromic AVRT is faster than other forms of SVT. So it shows this non-specific change in ventricular depolarization. But pseudoelectrical alternans can occur with AVRT, with AVNRT, or even with atrial tachycardia, but it is more common to appear with AVRT. Let's see this example here. We can see that there is regular non-complex tachycardia. Some doctor may say that I see this is sinus rhythm, but of course it's not sinus rhythm. It shows that there are negative P waves in inferior leads, positive P wave in AVR and in AV1. So I'm speaking about retrograde P waves. They are not sinus P because the axis here is in the opposite direction to the sinus P wave, and it appears as well in lead 2 strip. So this is not sinus rhythm. I am speaking here about SVT, which shows long RP interval. So this is long RP tachycardia suggestive of atrial tachycardia. And why don't I diagnose it as sinus tachycardia? Its answer is simple. It is long RP tachycardia, yes, and so we have three possibilities like atypical AVRT, atrial tachycardia, or sinus tachycardia. But look at the P wave axis. If the P wave axis in the long RP tachycardia was positive in 2, 3 AVF and negative in AVR, and negative or biphasic in V1, it is sinus tachycardia. But if it is, for example, negative in inferior leads, positive in AVR V1, I'm speaking about ectopic or focal atrial tachycardia arising from an abnormal focus other than the SA node. So of course the ECG axis is very suggestive for the P wave axis, is suggestive whether it is sinus tachycardia or atrial tachycardia. So here we have two possibilities. It may be atypical AVNRT or it may be atrial tachycardia arising from low atrial focus. And just to note, of course, there are some algorithms that are used by electrophysiologists in order to localize where is the origin of atrial tachycardia according to the P wave morphology and axis, like Kessler algorithm and Ellenbogen algorithm. But of course, I'm not dealing with this here because it is not our matter in this lecture. Now, of course, we have another example of long RP tachycardia, but here, of course, we can see the P wave axis, which is normal P wave axis, seeming like sinus P wave. So this is an example of sinus tachycardia, just sinus tachycardia. It is not an SVT. So although sinus tachycardia is a subtype of long RP tachycardia, but it is, of course, a completely separate diagnosis from SVT. So here, of course, I cannot mention that this ECG shows like atrial tachycardia or atypical AVNRT just because of the long RP interval. No, it is just sinus tachycardia as the normal P wave axis and morphology. Remember, of course, that the key to diagnosis of atrial tachycardia is to detect P waves of an unusual morphology and or axis distinct from sinus rhythm. So whenever you see that the axis and the morphology of the P wave in the rhythm is slightly different from the familiar P wave morphology in sinus rhythm, at that time you should suspect atrial tachycardia. So in order to summarize how to differentiate between sinus tachycardia and atrial tachycardia, because sometimes it is very difficult, like for example atrial tachycardia arising from upper crista terminalis near the SA node, the axis may be slightly nearer to the axis of the sinus tachycardia. So how can we differentiate it? First of all, we should check if there is old ECGs available with the patient and compare the P wave morphology and axis in the current ECG with the old ECGs if there is any difference. If there are no available old ECGs, so just stick to checking the axis and morphology of the P wave, and if there is any abnormal axis or morphology, suspect atrial tachycardia. But if the axis of the P wave is positive in inferior leads, negative in AVR, negative or biphasic in V1, it is just normal axis and morphology, and so it is sinus tachycardia. Sometimes it may be still difficult, and that time we may need to use another method like giving IV adenosine. IV adenosine in atrial tachycardia, which leads to transient second or third degree AV block without affecting the atrial rate. Whereas in sinus tachycardia, it shows the same AV block but with slowing down of the atrial rate or even transient pause of the SA node. So adenosine can slow down or cause transient pause as the SA node, but it doesn't do the same in atrial tachycardia. So sometimes adenosine will do this to differentiate between sinus and atrial tachycardia. And I would give you a link for the videos that shows the description or an example of giving IV adenosine in patient with atrial tachycardia. Remember, of course, that management of SVT in the ER doesn't need you to determine the mechanism of SVT. And according to the AAC guidelines of supraventricular tachycardia in 2019, just if you detect that there is SVT and you make a diagnosis of SVT in the ER, just manage the ER the same without paying attention to determining the type in the ER. Because the difference in the long-term management and the EP lab, yes, it depends on the subtype, but in the ER, management of all subtypes of SVT would be the same. So at the end of our lecture today, now we understand the types and the mechanism of supraventricular tachycardia. We learned today how to detect SVT in ECG, what are their criteria, how to diagnose them, and how to classify SVT with its subtypes. And remember our take-home message today: record the ECG during SVT episode and after termination. And management of SVT in the ER doesn't need you to determine the mechanism. Management would be the same, just it is SVT. Thank you very much for your listening.